Hello, welcome to this focused video, which will be a primer on antibiotics. And in it, I want to give just a few focused tips, 5 top tips when learning antibiotics, and a bit of a refresher if you're struggling to think about the topic or you just want to kind of brush up on it. Along the way, what we will be doing is I will go through the 4 main groups of bacteria, which are the most important when thinking about antibiotics. I'll give you examples of all of those groups of bacteria. I'll give you tips on the rules on where we find these bacteria in and on the body. We'll go through some of the key questions that explain why antibiotics are chosen to treat particular infections. Remember that it's not enough just to memorize guidelines. That's a bit of a waste of time, to be honest. It's much more useful to be thinking about why antibiotics are chosen, and that often is boiled down to 3 questions which underpin, which I'll come on to. And lastly, I hope to provide just a little bit of reassurance. Learning antibiotics is really difficult, and lots of healthcare students and future prescribers from around the world report that they kind of struggle to learn about antibiotics. What I want to try to do here is just to provide a little bit of a reality check and a little bit of a focused series of videos which will help. So I'm going to give you 5 tips. My top tip number 1 is to focus not on learning dozens of drugs, but just on focus on this select list I've picked. These are relevant to Southwest England. They may differ from other places around the world if you're watching internationally. Number 1, amoxicillin and co-amoxiclav. Number 2, ceftriaxone and cefotaxime. Number 3, vancomycin and azithromycin. I'll produce a separate video on these. They're chemically different to each other, despite their names. They're not kind of related to each other, and they're useful because they can target specific groups of bacteria. Piptaz and cefepime are chemically cousins of each other, and they have similar spectrums of activity, but there are 1 or 2 important things to say about them, so I'll produce a separate video on them. It's worth thinking and learning about aminoglycosides, and I'd recommend gentamicin as a good example of an aminoglycoside. And lastly, carbapenems are a very, very important group of antibiotics, so-called last-line antibiotics, and I will use meropenem as an example to describe these. So I will produce separate videos on all of these things, and I will refer back to this introductory video to cover some of the most important rules, which I'll go through. Tip number 2. Try to avoid rote learning guidelines. At the end of the day, you can download the guidelines to your phone. You can do that to help you avoid memorizing guidelines. Learning antibiotics isn't a memory test. At the end of the day, it's much more useful to be asking yourself, why do I think a patient that I see on clinic, in GP, or in the hospital or wherever, why do I think they're on that particular antibiotic? And if you can try to think along those lines, it makes it a bit more meaningful. My 3 top tip questions to help you with this are as follows. Number 1, does the drug cover or kill the bacteria that you suspect are the most likely causative agents for that person's infection? The second, that's often overlooked, is whether that drug actually gets to the site of infection. That's such an important question to ask. Different drugs have different chemical properties. They behave differently in the body. Some will accumulate at particular tissue types. Some can't be absorbed orally. Some get excreted readily and quite quickly. That can be useful in each of those different things at treating infections at particular sites in the body. Lastly, think about how a drug is delivered. Is that person being prescribed a drug orally? Are they being prescribed intramuscularly, intravenously? How often it will be monitored? How often do they need to take that drug? All of these things help to inform the guidelines that you're learning about. And these 3 questions, when you're asked about and you're on the clinic, refer back to these 3 questions. And nearly always the answer about why a patient is on a particular drug is ultimately boils down to these 3 questions. Tip number 3, try to avoid the following terms. Now, these are words which you'll hear a lot, and infectious disease doctors really dislike them. They'll dislike the term stronger antibiotics or better antibiotics. Of course, you can tweak the dosage. Dosage can go up as well as down, but there's really no such thing as a strong antibiotic. Each antibiotic is context and case dependent. So a good example is when you're treating someone with syphilis. Syphilis, which is caused by the bacterium Treponema pallidum, can be treated with penicillin. Now, we wouldn't really describe penicillin as a, quote, strong antibiotic. It works by killing this particular bacteria. So in this case, what we would describe as penicillin, which has been around for decades, works. That's what I think people mean when they talk about stronger antibiotics. Another thing to think about is, sometimes people will talk about, we need an antibiotic to cover all bacteria. Remember that ultimately, bacteria often resist certain antibiotics. Antibiotics, to look at it another way, exert a spectrum of activity. If you had someone that you genuinely wanted to cover all bacteria, they'd need to be on about 6 or 7 or 8 different types of antibiotics to do that effectively. Instead, try to think along the following lines. Think about broadening coverage to include a particular organism. So if someone is being prescribed an antibiotic, maybe that person isn't getting any better, you may want to consider either adding another antibiotic to broaden the coverage, to widen that spectrum of activity, to kill bacteria that you think you may not have thought about to begin with. Or sometimes they may switch antibiotics that in itself has a broader spectrum of activity. Potentially, you might be thinking about along the lines of maybe the organism that you're treating, that you had in mind to begin with, actually maybe you're treating an antibiotic-resistant version of that organism, and therefore you might want to switch your antibiotic up to maybe cover or kill the same narrow range of organisms. But maybe you need to change the antibiotic so that you're no longer, or that you're providing a drug that the organism is no longer resistant to. So try to think along those lines. Before we go any further, though, I wanted to provide just a little bit of reassurance, because, as I said, learning antibiotics is difficult. And quite often what people think about when they think about antibiotics, and often the way that it's taught, particularly in the preclinical years, are charts like this, charts which are technically correct. They have lots of information, but they are very dense in terms of information. People get, I think fairly, they get overwhelmed. They look at it and they just think, I don't know how I'm supposed to learn, what I'm supposed to learn. Are there some which are better than others? Here's the reality. The reality is that as a junior doctor, you will be more often than not referring to guidelines. You will be opening up your phone or an iPad or a computer. You will be looking up common infections and you will be prescribing according to what you're told. In situations where there are potentially more complex infections, or maybe patients aren't responding to antibiotics readily, you will be involving infectious disease doctors, probably at the end of a telephone, who will be advising you from the laboratory, where they'll be trying to identify organisms from the laboratory. You might say, well, okay, in that case, why do we learn about this stuff? We learn about it from a number of different reasons. One is that there's an increasing pressure on prescribers of antibiotics to know something about how these drugs work. Secondly, I guess it's more of a kind of a professionalism type area. Do we want prescribers in the future to have no idea about the drugs that they're prescribing? And the third is about, again, helping people understand that these drugs are crucial for medicine and we need to treat them carefully and with respect. When approaching antibiotics, it's not about memorizing charts like the one I've got on the screen here, but it's about thinking about those 3 important rules which underpin why an antibiotic is selected. Tip number 5, this is something which I'm going to refer back to over the series of these videos. There are 4 important groups of bacteria which are relevant to the antibiotics. So the gram-positives and the gram-negatives come to mind. These are bacteria which have different cell wall structures. You'll have a third group, which is sometimes just referred to as atypicals. These are bacteria with either no cell wall or can't be gram-stained or have unusual life cycles. And the fourth are anaerobes. The anaerobes can sometimes be both gram-positive or gram-negative. Remember, this refers to their cell wall, not the way that they breathe. But we talk about anaerobes under a 4th separate category because the way they respire can allow us to target these particular organisms specifically with particular antibiotics. So let's go through a few specific examples of each of these things. With the gram-positives, a really important organism to be mindful of is Streptococcus and Staphylococcus and Enterococcus. We'll start with Staphylococcus. With staph, you can have what are called methicillin-sensitive Staph aureus and methicillin-resistant Staph aureus. So MRSA sometimes goes by the name MRSA, particularly if you're watching videos from the United States. Streptococcus, these are the bacteria which grow in chains. They can include group A strep or strep pyogenes, and it also includes the pneumococcus. Pneumococcus actually appears as diplococci, so two cells stuck together, and strep pneumoniae is a really important respiratory tract infection organism and also an important cause of meningitis. And thirdly is Enterococcus. And this is, as the name suggests, it's an enteric dwelling gram-positive or an entero organism. So this is a gram-positive cousin of Streptococcus. Within the gram-negatives, we've got what are called the enteric gram-negative rods. That includes things like E. coli. It includes respiratory gram-negatives. So for example, Haemophilus influenzae. This is an important cause of respiratory tract infections, and you'll see this a lot in, for example, ENT placements. And then also Pseudomonas. And Pseudomonas often gets kind of special mention when thinking about antibiotics because it comes loaded with lots of different antibiotic resistance mechanisms. When thinking about atypicals, there are three, which I'm going to come back to. They're Legionella, Mycoplasma, and Chlamydia. Legionella is interesting because it forms intracellular infections. Mycoplasma is interesting because it has no cell wall. Note that Mycoplasma and Mycobacterium are different. So Mycobacterium that causes TB is not the same here. And I won't be mentioning that in these videos because it's a very specific class by itself that's treated with its own drugs. And Chlamydia, which has been renamed, is also important. And that's an interesting organism which has a multi-stage life cycle, which is kind of unusual for bacteria. And then lastly, for the anaerobes, all I really want to kind of remind you of here is that there are both oral dwelling anaerobes and GI dwelling anaerobes. Oral anaerobes can often be treated by dentists. So dentists can prescribe antibiotics. They quite often prescribe a drug called metronidazole to treat oral anaerobes, and GI dwelling organisms, which can include important hospital bugs like C. difficile. So there we are, four main groups and examples of each of these groups underneath. Where do we find them? So as a reminder, the gram-positives, you'll find lots on skin and mucous membranes, thicker cell wall that can survive drier environments. So again, staph and strep can cause lots of respiratory tract infections and also skin infections. Gram-negatives, thinner cell wall, they can dry out a bit quicker. So you're thinking about lots of enteric, lots of respiratory infections. Atypicals, these cause infections of both respiratory and genitourinary tract. They can sometimes appear in other places as well, but these are a good starting point. And anaerobes, as mentioned, oral and GI. So expect lots in the mouth and sinus, and expect a lot in the large intestine as well. The large intestine is basically a massive anaerobic environment where organisms like these will persist. Crucially, and I've already mentioned this, when we're thinking about drugs, it's not just about killing bacteria on a petri dish. It's also about making sure that the drug gets to the site of infection at a concentration that does something. So when we're thinking about drugs that go into the body, we need to be thinking about, if we're giving a drug orally, can it survive stomach acid? i.e., is it broken down? Is it ionized? Can it be absorbed subsequently? If it's absorbed in the small intestine, how much of it is absorbed and how much of it is broken down? There are certain drugs which stay locked within the GI tract. That's useful if the site of infection is within the GI tract. If it's absorbed, how much of it is distributed throughout the body? Is it accumulated in particular tissue types? So there are some that accumulate in cartilage and soft tissue. That can be useful, again, if the infection is at those sites. And what about their excretion? Sometimes we want a drug that's both absorbed quickly and excreted quickly. And that's useful if, for example, you've got a urinary tract infection. Really handy. So thinking about the behavior of the drug in the body also helps explain why that drug is selected in the first place. So for now, we're going to focus on the following drugs, and each of these will be a separate video by itself, and I'll refer back to this introductory video. Thanks for watching.